is because you want to understand volume status on your patient. Yes, initially they're coming with hypotension and they're dry. That will not be the case tomorrow or the day after. So assess your volume status every day, because septic shock, patient can develop ARDS. And if they do develop ARDS, you need to back up. You got to go in the opposite direction now and deplete them. You get what I mean? That's why identifying the right, you have to find the sweet spot of volume resuscitation in your patients. Okay? Now, what is another important philosophy you have to follow with ARDS? Sedation. Obviously, when you intubate patients, you have to sedate them, right? When you sedate somebody, what is a score we like to use in the ICU? The RASS score, which is? What does it stand for?
Assessment scale.
Richmond Agitation Sedation Scale.
That word.
Okay? RASS score. Richmond Agitation Sedation Scale. It goes from 0 to +5 and then in the negative numbers. Most patients, what you want to do is, what RASS score do you want to target? 0 to -1. Because when you go 1, 2, 3, 4, is patients getting more agitated. Okay? When you go negative, is more sedation. -1, mild sedation. The patient can still open the eyes, they can communicate with you and whatnot. -2, a little bit more sedation. -3, -4, you're going to be comatose. So most of your patients, important thing is you typically would target a RASS score of 0 to -1. Very gentle sedation in the ICU, not more. But when it comes to ARDS, what do? You will do deep sedation. There are only a few instances in the ICU that you would actually do deep sedation. One of them is ARDS, and that's a board question. So deep sedation for ARDS, everybody else 0 to -1. What are the other two instances where you would actually do deep sedation? Huh? Seizures, very good. So if somebody's got status epilepticus and you sedate them, they need to go to deep sedation. Alcoholic with delirium tremens. Delirium tremens, also you want to go deep sedation. So these are the three instances that we need to have deep sedation. Everybody else, very mild, very gentle sedation. Now when you're supposed to do sedations for patients, right? Are you supposed to give continuous drips, or are you supposed to give interrupted pushes? It might be very different from practice.
Pushes.
Interrupted pushes is what you're supposed to do. You're supposed to assess the patient's RASS score very frequently and give them as needed sedation, not continuous drips. Next question is, if you had to pick a sedation, tell me the first sedation that you will never pick as a first line. Let's get that out of the way. Which is the first sedation that you should never pick as a first line? If you've decided to intubate somebody and you want to start them on sedation, pharmacy is there like, hey doc, what sedation do you want? You're going to say, well, I do not want Versed, which is Midazolam, correct answer. Basically you're saying, I do not want a benzodiazepine. Why not? Never use benzodiazepine in the ICU because it causes ICU delirium. So no benzos for sedation, period. So benzos is bad. Okay? Never use benzos. But there's always going to be a but. I'll come to the but. Never use benzos as first line, period, for sedation. Okay? Now we've got benzos out of the way. What becomes your good choice for the pharmacist to bring for us as a first line of sedation? Huh? Fentanyl, you're going to go with Propofol. Which one should we pick? Fentanyl or Propofol as the first line? They both are going to work. Well, yes, fentanyl is going to have more analgesic properties. You have a point there. But you can also give IV pain medication. So if you had to pick hand in hand and compare fentanyl versus Propofol, who likes Propofol? Who likes fentanyl? I know the white bottle looks cool and all, but really, is it good? And we do have a fentanyl problem in the US as well as the world. People abuse the drug and whatnot, so both of them are bad. But in the ICU, to get the job done, you would go with? Etomidate is more for intubating somebody. You know, etomidate, you know, your succinylcholine, all of those things are more for intubation. This is more for even ketamine you could use. But once you've intubated somebody, you need a sedative. Your typical choices are fentanyl, Propofol, you have Midazolam, which is benzodiazepine, and you also have now Dexmedetomidine, which is Precedex. So these are your four. So which one would be a good first line agent to pick on most patients? Which one do I have a problem with? Seems like Propofol I have a problem with. Okay, good. Why do I have a problem with Propofol?
Yeah.
Okay, you guys are saying a lot of important points. So you're saying there's too much triglyceride. Why does it look white? Because it's very fatty. It's got a lot of triglycerides in it. If you're going to give somebody too much triglycerides in an IV line into your blood, what's going to happen? You can have too much triglycerides and you can cause pancreatitis. Why? Why does hypertriglyceridemia cause pancreatitis? And more than how much hypertriglyceridemia does it have to be for it to cause pancreatitis?
It's like over 1,000.
More than 1,000. Typically the number is 866. After 866, you're at risk because any next meal you eat, it's going to shoot up above 1,000. Okay, so the moment it goes above 1,000, now you have a problem. Because more than 1,000, the triglycerides are going to get broken down to give you what? What is triglycerides in biochemistry? You guys are all a big bunch of biochemistry, you know that, right?
Oh, the fatty acid.
So triglyceride is glycerol 3-phosphate plus 3 free fatty acids. Break it up. 3 free fatty acids. Now where is this breakdown going to happen? In the liver, in the biliary tree. Now triglycerides are going to come in the biliary tree. The bile is going to break it down and you're going to release a lot of free fatty acids. What does the free fatty acids do to your biliary tree? It's irritated. So once it irritates the biliary tree, you're going to have inflammation, close it off, back pressure, it's going to cause acute pancreatitis. So you can actually cause hypertriglyceridemia induced acute pancreatitis. That's one problem I have with Propofol. What else do I have problem with Propofol? It is fentanyl. Fentanyl is a good one to pick as a first line. Fentanyl does not have much side effects. You can start fentanyl and fentanyl is going to be the best choice given the circumstances in your patient. So fentanyl is always going to be my first line choice when I have to pick sedation. In most patients, there's always a but. Propofol, I can add on to fentanyl if one sedation is not enough. Don't think that one sedation is always going to get the job done. I've had patients where I've had to have 3 sedatives or more. Fentanyl as number 1, Propofol as a number 2. You said Precedex, which is Dexmedetomidine. It is a new sedative. It's a good sedative because it is very gentle and there's risk of less delirium. Patients are more conscious. It gets the job done much better. But there is still a problem with it. One is cost. I don't care about the cost bit so much, but from a pharmacology standpoint, what is my problem with Precedex? Yes, because if you think of an anti-hypertensive drug that works exactly the same receptor as Precedex, which drug is that? Clonidine. Clonidine, it works on central alpha-2 receptors. That's what Precedex works on. So if it's working like clonidine, it's going to cause hypotension and bradycardia. Giving a patient with septic shock, who's in shock, any drug to drop blood pressure seems like a bad idea. It's not like fentanyl cannot drop blood pressure, it can. But Propofol and Precedex can do more to drop the blood pressure. So fentanyl first, you're going to go with Propofol next. Precedex is a good one to use, but never really as first line per se. So when is benzodiazepines your first line choice for sedative? Is there anything different with hypovolemic shock? We don't need antibiotics obviously, but you're going to give them fluids, pressors. Okay? What's that? Blood if they're bleeding. Would you use steroids in a hypovolemic shock? No. The whole concept of steroids on the context of shock is solely isolated to septic shock. It's very unique for septic shock, not any other type of shock. What about cardiogenic shock? Say somebody's got cardiogenic shock. Are you going to give them fluids? No. If the patient clinically looks fluid overloaded and the patient's got cardiogenic shock, they will have decreased cardiac output and they're going to have back pressure and that's going to cause pulmonary edema. So what are you going to do first? The patient's blood pressure is low, but they look fluid overloaded, they got CHF, you know they got CHF, blood pressure is low. What's your choice to solve the problem? You're going to start pressors. And what pressors are going to pick first? Norepinephrine, not Dobutamine, not Milrinone. You will drop that blood pressure. Start with norepinephrine. Once you have the norepinephrine, bring the blood pressure up. Now you can add your Dobutamine or Milrinone as an inotropic agent. Next, when we go to obstructive shock, you got pulmonary embolism. When you think about pulmonary embolism, why does that cause an obstructive shock? Because imagine you had a large PE and the large PE is sitting in your pulmonary arteries. If it's so large that you can't push all the blood through, you've got to put too much back pressure into the ventricle, but also you have no blood going to the left side of the heart. If no blood goes to the left side of the heart, you're going to have drop in your blood pressure and therefore you're going to become a shock state. So what are you going to do in a patient with a massive PE? Remember, when you talk about pulmonary embolism, there's three types: benign PE, submassive PE, and massive PE. Massive PE is when somebody's got hemodynamic instability and shock. What is submassive PE?